We're live on Facebook. I'm
Hello,
sorry,
everybody.
YouTube. And I'm gonna go live. Hi, everyone. Happy Friday. On Instagram. I'll tell you when to refresh.
Okay. Well, I'm doing it every 5 minutes because it doesn't refresh at all.
All right, we're live on Instagram, so you should be able to refresh. Hi, everyone. Happy Friday. Let's see.
Okay, I'm on. I'm waiting to ask me to join, and I'll
Oh, I see you. I
here.
see you. Okay.
I sent
Hi. Hello,
I sent you the
hello.
request.
I'm gonna add you now. This was quick. This was quick.
Yeah, for this old toady person, yeah.
Hi, Weebreeze. How are you? We
Hello,
got the
everybody on Instagram. Here we are. Somebody tell us where you're coming from.
Hi, Pink Khalid. Hi, Big Boy Cells. I like the screen name. Hello. Hi, Alegu Angela. Hi, Kevin. Oh, nice to see you
I'm sorry
guys.
somebody's having a pain crisis right now.
Oh,
What a bummer.
really? I'm so sorry. So
Yeah,
sorry. Not a nice way to spend Friday.
no.
Ugh. Jersey. We got Jersey in the house. We got North
Yeah.
Carolina. We got Pennsylvania,
Jamaica. Hello,
Jamaica.
Jamaica.
We always get a lot of Pennsylvania. What's up with you guys in Pennsylvania? Like, there's always a lot of people there
Hello.
that would sickle cell.
Yeah.
Hey, we got Callie in the house. Tuning in from
Brooklyn.
Togo,
Oh,
but from New
Brooklyn.
Jersey.
Whoa.
Wait, you're in Togo?
Nigeria.
I wanna go
Uh,
there.
Cyprus.
You don't hear
Wow.
too much about Togolese people. You guys just mind your business. Good for you. Unlike us Nigerians. Don't mind me. All right. Um,
Oh,
and then
Ghana.
hi Brooklyn. Brooklyn, that must mean you're in the Bay Area with us.
Kenya. Wow, we're getting a lot of people
And
from,
Cyprus. Oh my gosh.
yeah.
Fantastic. Okay, so let's see who's gonna put the first question in the chat here. Houston, Texas. You said, yes, I am. We do mind our business. You can come visit next year. Good for y'all. Good for y'all. Um, hey, Ninja. All right. Mississippi. All right. Should I start us off with our first question?
Here's
Or
a
does
question.
somebody
What
have?
kind of doctor is Dr. Q?
Oh,
I'm a
that's a good question.
pediatrician. And before that, I was a nurse for about 10 years. I was a critical care nurse in the ICU. Went to school at Case Western in Cleveland, Ohio. Then came to Oakland to do my residency because I'm from Oakland. And then I got a job at a private practice, but I always kind of wanted to go and do hematology. I got accepted into a fellowship, but things happen and I didn't do that. But I ended up being the sickle cell doctor at Children's Hospital for 20 years and took care of a lot of kids. So that's kind of, and I'm still helping community-based organizations and stuff like that. And I'm old. I won't tell you how old I am because then you wouldn't listen to me. I'm older than some of the candidates that are.
Well, it's very easy to be older than Kamala Harris.
Yeah.
All
She looks
right.
pretty good, I'll tell you. I wish I looked that good.
All right. We got our first question here. I want to know what you think about hydroxyurea.
Oh, you're talking to somebody who really likes hydroxyurea. So hydroxyurea has been around for a long, long time. I mean, decades. It was first used as a cancer medication, but people realized that when they gave it to people with cancer, their fetal hemoglobin went up. So some smart person back in the 80s or so thought, hey, well, maybe if we can titrate this dose and figure out what's the best dose to give people who have sickle cell disease, because fetal hemoglobin inhibits sickling. And there's a lot of other, well, we found out later there was a lot of other stuff. And so they started giving hydroxyurea to people with sickle cell disease. There were a lot of case studies that showed it was helpful. And then they did a large study and showed that people on hydroxyurea had half as many episodes of pain and half as many episodes of acute chest syndrome than people who weren't on it. So it was approved for adults. People like myself who are pediatricians some people started giving it to children to see if they had the same side effects. They did. And so they started giving it to children, but it wasn't until 2007, I think, when a company did a placebo-controlled trial to show that it worked in children as well as it worked in adults. And so now it's FDA approved for adults and children. It doesn't, it doesn't work for everybody. There's probably the very small percentage, maybe less than 5% for sure, where it just doesn't seem to work. But if it doesn't seem to work and you're taking it, then what you need to know is, are you on the right dose? If you're not on a high enough dose, it's not going to work. If you're on too high a dose, it can cause some side effects. So you have to have a doctor who's familiar with hydroxyurea, who's looking at your blood counts and realizes that by looking at your blood counts, it looks like we could increase your dose a little bit. And sometimes that will get your fetal hemoglobin up. But even if it does, nothing in medicine is 100%. So it's not going to work for everybody all the time. If you have SC disease, I don't know, someone said SC, I don't know if that's SC or sickle cell, but in SC, it won't work. It seems to work best if people have a low-ish hemoglobin. If your hemoglobin is too high, means your bone marrow is less active, and that doesn't work as well in those kinds of people. And people like with SC, S beta plus thalassemia, it doesn't tend to work. Although, if you're really sick, I did give it to some people with SC if they had a lot of pain episodes, and I think it worked for most of them. I can't remember. It was a long time ago.
Hopefully that helps. I just want to let you know, we'll talk about Oxbryta, guys. I see a couple questions about it. I see someone here that says, what do you advise for a 2-year-old daughter? She has had a swollen arm for 2 weeks ago. So swelling is common in infants with sickle cell. It's actually one of the if there is no newborn screening within your country, it's actually one of the indicators that you should get your child tested for sickle cell. So why does swelling occur, and what can this person do for their child?
So children respond pretty well to acetaminophen, Tylenol. So that is basically a pain episode in a young child. You should, if that's happening, you should really go see your primary care doctor or hematologist, someone who can just make sure that that's what it is, and make sure that your child hemoglobin and all their blood work are okay. Frequently it happens in your hands, and it's called dactylitis, and the little kids' hands really swell up, and they are obviously in pain. They don't use that hand very much. So it's if that's what it is, and I can't tell because you're virtual, but if that's what it is, then pain medicine like acetaminophen should be okay. If it was really bad, some people would give opioids, but my experience and what I've read is that children do well with acetaminophen, better than adults. It doesn't, acetaminophen kind of doesn't really take care of pain in adults.
Yeah.
But make sure you just call your doctor, make sure you get your baby gets looked at, and that's what it is. It's not like she fell and has a fracture or something. It's inflammation, and it can't even be bone damage from sickle cell. It heals itself, but that's if some people have done X-rays and dactylitis or hand swelling and shown that the bones are affected by the sickle cell event.
Yeah. Um, I used to get swollen hands when I was little too. Although I don't think I was a baby. I think the swelling continued even when I was a little kid. I don't know if that's common or not, Dr. Q, but my hands would swell if like I touched something cold. And so I never had to put away groceries. And all my siblings had to because no, my hands they'll swell. So I can't help. Sorry. But yes, I that's something I experienced as a kid, the swelling. And so it's a kid thing, right, Dr. Q?
It's a kid thing, but adults can have swelling as well.
Okay.
It's just not as noticeable in adults because you have more
Yeah.
muscle mass and stuff like that. But you do
Okay.
probably, if you did an MRI of everybody who had a pain episode, you'd see swelling around the area.
Yeah.
Okay.
Yeah. Okay. All right. I'm gonna dive into Oxbryta and see what kind of questions you guys have about Oxbryta. This person said Oxbryta has been taken off the market all over the world. What are we going to do?
Uh, well, Oxbryta was this is how, just so everybody starts at the baseline. So
Yeah.
Oxbryta was developed in order to hold hemoglobin in the oxygenated shape. Hemoglobin changes its shape when it's got oxygen in it versus when the oxygen leaves the hemoglobin. And when it takes on oxygen in your lungs, and as it goes out into your body, it loses the oxygen. As it does that, it changes its shape. It physically looks different if you could look at it with some kind of microscope or whatever, but it physically looks different once it loses the oxygen. And that difference is why it allows it to polymerize or make the long chains of hemoglobin that are the basic problem with sickle cell disease. So the scientists at Global Blood Therapeutics, which is now owned by Pfizer, they developed a small molecule that would attach to there's four molecules in one molecule of hemoglobin, and there's two alpha globins, there's two beta globins. You don't need to know that, except that the Oxbryta attaches to the alpha hemoglobin, and it makes it change its shape as though it was carrying oxygen. So that by doing that, it stops the sickling, because if your hemoglobin is oxygenated or looks oxygenated, the shape is in the oxygenated shape, then it doesn't polymerize. The consequence of that is that your hemoglobin goes up because it's not polymerizing as much. And some people in articles I've read think that, that's not really the best way to treat sickle cell disease or sickling hemoglobinopathies, because it's while the chemical, the Oxbryta, is on that alpha globin, it can't carry oxygen. So part of your blood is unable to carry oxygen when you take Oxbryta. But but because there's less hemolysis, your oxygen slowly goes up a little bit, a gram and a half. Some people who know a lot more about the biochemistry or scientists, I'm just a pediatrician, they feel like the trade-off is part of your oxygen, part of your hemoglobin doesn't carry oxygen because the oxbryta is attached to it. And so even though your hemoglobin goes up, the amount of oxygen your blood is carrying is about the same because some of it can't carry oxygen because it's got the oxbryta on. The other 50, 60% or more can carry oxygen. And they think it's kind of a wash. As your hemoglobin goes up, but your oxygen carrying capacity, your ability to deliver oxygen to the tissues doesn't change that much. So that's sort of the story with Oxbryta in a study in Africa with kids who were at risk for stroke. I don't know about this. I don't know anything about this study because it's never been published. So I don't really know except what I've heard from people that I know. There were more children who did poorly on Oxbryta than the children who weren't on Oxbryta to try to prevent stroke. They felt that if you increase the hemoglobin and decrease sickling, that this could be like transfusions to prevent stroke. And I don't know if these were kids with abnormal um, uh, uh, transcranial Dopplers or not. I don't know that much about the study, but what I've been told was that and maybe other information that I don't know about led Pfizer to discontinue that medication. They felt that the it, that the downsides of it were higher than the upsides, and so they decided they would just stop distributing that medication. Pretty surprisingly that they did it just, Monday you could get Oxbryta, Tuesday you couldn't. It was like there was no kind of time for you to figure out what to do. You just the next day, if you didn't have it in your bottle at home, then you didn't get it. You couldn't get it anymore. So is the
There's a if the FDA requiring Pfizer to provide data since it was still in clinical trials, Pfizer says they won't produce data.
I you know I don't know the I've actually helped when I was in practice. I helped people with not with I was a transfusion medicine person, so I did go before the FDA, but I think I'm not sure that they actually have a mechanism. They might. I could look it up, but I don't know if they have a mechanism. If they've approved a drug and the company withdraws that drug, I'm not sure that the FDA has any authority to tell that company, we want the data, we want to know why you withdrew that drug. I think they can voluntarily give that data. They could
Yeah.
publish a paper with the people involved in the study and their scientists and other people and say, this is why we did this. But there's no reason for them to do it. It's just their goodwill and to do something like that. I don't think the FDA has the authority to get this what's called proprietary information. The information that they have is their information. They may want to use that in the future. They don't have to tell anybody. It's like if you develop a drug, you don't really have to have that the information available. It's proprietary. It's your information. You don't have to give it to anybody. So
What I was told on a call, because I have been in communication with the Pfizer team, is that they are continuing to look at the data. So obviously the data was compelling enough, the data that they did have or that they did look at was compelling enough to pull it off of the market. However, they haven't looked at like all of the data, right, to understand the full story of what's happening. And so they do want to look at all of the data, and this includes post-market data. So if you're on Oxbryta, you were part of post-market or post what is it, post approval data. That study in Africa that they did to see about strokes. There was also another study that they did to see how Oxbryta might work with leg ulcers as well. And so they have to take, so some of those were pediatric studies, but also like, you know, post-market data studies includes adults as well. And so they need to kind of look at everything and the full picture to really provide the answers that we're looking for in this. If they were to answer questions and it's from a smaller amount of data, um, I guess what we were told is they want to look at everything so that they can give us the best answers. Um, so that's what I was told on our calls with Pfizer. And yeah, it's a waiting game to kind of just see if we get it to get to learn more about what's going on and why they pulled it off and you know what that data says.
it's a big deal because
Yeah.
they have to look at this because it would really it could if their data is sort of negative, then it would
Mm.
indicate that changing the molecule, the hemoglobin molecule, is not a good way to treat
Sickle cell.
sickle cell disease. So
Mhm.
I'm sure there's a lot of interest in doing this because voxelotor or Oxbryta was so effective that they want to make sure that when they come out with an answer, it's very definitive. It can't be
Right.
wishy-washy, whatever. And so they have to look at a lot of data. They have to have a lot of doctors look at the data, a lot of scientists, and they have to get a general consensus. Not everybody agrees about everything in medicine and science. So they really have, before they come out with a statement, it can't be, it's got to be airtight. They've got to make sure that what they thought, the reason why they pulled this drug was legitimate and there was really a problem, and that having a drug that increases hemoglobin by mimicking oxygen is not a way to, it's a big deal because it would take a lot of studies that are in progress right now, and just that would be the end of them. So they have to be very, very careful and thorough, which is going to take a while, 6 months or more. It's not an easy thing to
Yeah.
do. There's a lot of people involved.
Somebody said my son has been on it almost 2 years and has been doing great on it. This is the experience of a lot of people. A lot of people say Oxbryta has helped them, which is what makes this so complex. You know, it'd be one thing if like everybody hated it and it did nothing for anybody,
Right.
but it actually did help people. And so those people, I see the question a lot. So what do we do? Like, you know, I've gotten the question, and just full disclosure, I was on hydroxyurea. I'm not, I was on Oxbryta myself. Um, and the question is, so what are you going to take now? And it's like, so I'm on a hydroxyurea and I'm on Oxbryta, and there isn't an alternative. There isn't a replacement for Oxbryta. There isn't. You can, if you're not already taking hydroxyurea, you can try hydroxyurea, but like if that product is gone, it's gone. There isn't a replacement. there isn't a drug therapy replacement now. So people have talked about, going back on transfusion or going back to apheresis. I know my sister, so my sister's also on Oxbryta too, and she is going to continue apheresis while taking hydroxyurea. So there really isn't an alternative. It's gone. And so it requires you to go back to the drawing board with your provider and see what options work for you. And that could be blood transfusion. That could be hopefully, if you're taking Oxbryta already, hopefully you're already taking hydroxyurea. But if not, maybe it's, starting hydroxyurea. And then there are some other therapies that I don't necessarily want to mention, but that are, I think, still on the market. Like I think Indari is, but just from what I'm hearing, everything is just so shaky with drug therapies and sickle cell right now that um, hydroxyurea has been the steadfast. Hydroxyurea has been around for the longest. It has the most data behind it. And so hydroxyurea is still that like reliable option. And then, like if you have access to transfusion, um, that could be another way.
Yeah, I think what you really need to do, everybody's experience with sickle cell disease is different. There's really not two people who have sickle cell disease who can find another person who says, well, my sickle cell disease is exactly like yours. That
Yeah.
really is very unusual. So you really need to talk to your primary care physician, the person who prescribed the Oxbryta for you, to give you some advice about what you should do now that you don't have Oxbryta.
Yeah.
You might have to wait a little bit because everybody who is on it is kind of freaked out and wants to know, what do I do now? So try to be the first person to get in touch with your primary care for the doctor so you don't have to wait in line to figure out. Or maybe your primary care doctor will have a statement that they give to everybody, but you can't really do that because everybody's different. So you got to go in, see your doctor, get
Yeah.
their advice as to what you should be doing now, because everybody's different. People,
Yeah.
I mean, they may discover that some people it works well and it's okay, and for other people it's not.
Yeah.
It just don't. I can just tell you, it's gonna take 6 months or something
It's going
for
to take a
this to
while,
settle.
guys.
It's not
Yeah.
gonna be tomorrow. There's too many people involved. There's too much at stake. They want to be sure that when they come down on it, they want to be sure that they're absolutely right.
Yeah.
They can't, you can't do something like this and then make a statement and then later find out that was not quite right. That would not fly very well. So they're going to be when they come out with a statement, I think it's going to be very definitive and backed up by a lot of science and a lot of clinical information.
I also want to add to this that it's been advised not to stop Oxbryta abruptly because it can cause, and you know what, I'll just share my experience. I had a lapse, or I changed insurance and I had a lapse of taking Oxbryta. And I didn't know that you couldn't stop it abruptly. And during that time when I didn't have Oxbryta, and just please take this is my own personal experience. So take this with me just as that. But I know from me, it put me in a lot of pain. It put me in like, crisis, like just all over my whole body was in pain because I had stopped Oxbryta abruptly. And I was even considering, going to the hospital and being hospitalized because that's how much pain I was in. So I only share my experience to share with you that, um, if you're stopping Oxbryta, be sure to wean off of Oxbryta, or, and don't take my advice, take your doctor's advice, whatever you you discuss with your doctor is the best advice, right? We're just two people online sharing our experiences and what we know, but um, the general consensus from providers is to wean off of Oxbryta instead of stopping it abruptly. So I just want to make sure you all know that too, because there is a question here that says, should I immediately stop taking it? Um, if by immediately that means like just stopping cold turkey, I guess, um then you should definitely wean off. If immediately means like, should I immediately start weaning off of it, then yes. They're not making it anymore, or you're not going to get it anymore. I should say, as of right now, right? There's some conversation for potentially for compassion usage and all that, but that stuff, I don't see it being available immediately, or like, in short term. And so you should expect to stop taking Oxbryta. And with that said, you need to wean off of Oxbryta.
Right. There are some what are called case studies,
Yeah.
which means that these are very rare events. There's not like a study with 10 people. It's like one. I've seen two case studies where people who, for whatever reason, stopped their Oxbryta cold turkey did not do so well.
Yeah.
And they ended up getting very sick. So those are case studies, but that it still means it's a possibility. There's not been like 10 people who, uh, but and I think most doctors are saying to wean. So
Somebody said
there's no compassionate use.
there
Someone
is
said that
somebody
online.
said that.
Well, someone said Pfizer said yesterday during a live that there will be no compassionate use.
Okay,
So
interesting.
yeah,
So yeah, so for those of you who are asking, do I need to stop taking it? You kind of don't have a choice. You
right,
don't have a choice. So it, the goal is to make sure you stop taking it safely. And if you still have, a certain amount, the best thing to do is to wean off of it instead of stopping abruptly.
right, and talk to your. I think a phone call. I don't know that your doctor might want to take a look at your hemoglobin after you've been off of it for a while, just uh, to make sure your hemoglobin doesn't take a big dive. But other than that, I think you just have to ask them, what's the best way? I've got X numbers of pills. What should I do? How should I
Yeah,
take? Should I we if I've got 100 pills, how long should I take? 2 weeks
right.
or whatever? You say, I've got 10 pills. What should I do? And they could help you figure out how to wean off.
It really does require that type of mapping, because when they stopped this, some people had only 2 pills left, some people had 75 pills left, right? So those two scenarios are very different for that, those people. So if you're somebody who only had 2 pills left, then you talk to your doctor. Maybe the doctor may supplement, or like say, hey, because you only have 2 pills left, I'm making this up, so please don't take this as medical advice, but you only have 2 pills left. Let's make sure you get a apheresis or a transfusion, because you only have so little left. Whereas somebody who has like 75 pills left, they can take their time weaning off of it. They have that capability. So it really is an individual thing that you have to discuss with your doctor. I'm just checking to see if there are any other follow-up questions surrounding Oxbryta. Um, You don't see any, do you, Dr. Q?
No.
Okay. Well, we're still here on the live. If any questions pop up about this, we really want to answer them and really want to make sure you have the information you need to manage this situation to the best of your ability and as safely as possible. So um, we're here, we're around. Um,
So, and you can, and I think you can expect that you will feel a little bit tired or fatigued
mhm,
when you stop. Your hemoglobin went up at least a gram. Some people it went way more than a gram. So
yeah.
depending on what your hemoglobin was prior to starting Oxbryta and what it was while you were taking Oxbryta, if that was a wide margin, you can expect that you're gonna as your hemoglobin goes down, you are going to get more and more tired. If you are concerned and you're really tired or you feel like you're really pale, then you might want to get your hemoglobin checked just to make sure it's okay.
I see a lot of follow-up questions or questions surrounding hydroxyurea, so I want to open that back up. A couple questions says I'm 30 and I've never been on hydroxyurea. Should I start or just continue as is? It's never too late to start hydroxyurea. Um, is the hydrea working or even worth trying? Somebody else said, should I still take hydroxyurea when I'm taking other antibiotics? And so, Dr. Q, can you
Sure.
um, address some of those questions?
Yeah. So you can start well, you can start hydroxyurea anytime you want. So you can start hydroxyurea in children who are like 3 years old. If you have a good, if you have to have Bottom line, you have to have somebody prescribing the hydroxyurea who knows a lot about sickle cell disease, has used the drug a lot, or they have access to someone who has used the drug a lot, because the side effects are not good if you take too much. Okay. So you need to have a doctor who knows how to prescribe it or access to somebody who knows how to prescribe it. Okay. So hydroxyurea does not work in everybody. And you can see as this scrolls through there, people say it didn't work for me, and it doesn't work for everybody for two reasons. Number one, maybe your hemoglobin was really high to begin with, and it doesn't seem to work as well in people who have high hemoglobins. Or you weren't on the proper dose and your fetal hemoglobin and the effects of hydroxyurea, they never happened because you weren't taking enough. Okay. Or you were maybe taking too much and somebody stopped it because your hemoglobin was going down, your white count was going down, whatever. Um, okay, so those are the kind of caveats. But if you're taking it and you're being monitored and you're on what's called the maximum tolerated dose, which is the dose they slowly increase hydroxyurea until they start to see side effects, and then they might back off a little bit and leave you at that dose. It has been shown in patients in Africa that if you take even a small dose that's lower than what you would get if you had here and you had a hematologist, it does have an effect on most people who take it. So I think that if you're not on hydroxyurea and you're worried because you had to get yourself off of Oxbryta, or even if you're just on nothing, you should think about hydroxyurea. I'm a big fan of hydroxyurea. I've had people I took care of do extremely well, and I've heard really other people tell me how well they did. My kind of stock story that I tell everybody over and over again is a close friend of mine, pretty close. So I think she's still my friend. I haven't seen her for a while, but she was on chronic transfusions, had a lot of problems, and she started hydroxyurea probably in her 50s, maybe 40s or 50s. And she got off of her transfusions. She didn't have more pain. She didn't go to the hospital. Now she's my age. She's like 77 and she's still on hydroxyurea and she's doing very, very well. And she looks great.
I was gonna add that. I was gonna, not only is she doing well, she looks good. She looks good.
Yeah, she's really quite the lady.
Um, so that's hydroxyurea. I am on hydroxyurea, like I said earlier. I didn't take it to be in less pain because when I started hydroxyurea, I wasn't in very much pain and I was only hospitalized once every couple years. And so the reason I started taking hydroxyurea was for organ preservation. So you know how sickle cell, even when we're not in the pain crisis, sickle cell is still sickle celling and still creating damage to your organs. Oxygen is still not being delivered. Cells are still sickling. Cells are still dying fast at a faster rate than, people without sickle cell. And so I decided to take hydroxyurea to preserve my organs so that you know, it slows down the damage of sickle cell, the damage of my organs that sickle cell creates. And so that's why I started taking hydroxyurea, not because, and a lot of people will start to take it because they want relief from pain, particularly. And I do believe some people do get like ultimately they get in less crisis and so on and so forth. But that wasn't the reason I started taking it. I started taking it because I wanted to protect my organs. And so even if it wasn't going to reduce my pain crisis, I was taking it just so that I can get that protection for organs. And so that's a little bit about why I started taking hydroxyurea. I started taking it as an adult, probably like at I'm kind of embarrassed to say, probably at like 30, maybe a little bit younger. And I'm embarrassed because Dr. Q's looking at me. Dr. Q is looking.
She's
He's like,
confessing
he's
to
like,
me.
I told you. I
I'm
told
going
you
to
to
give
start
her a
taking that
talk once we get
therapy.
off this.
I told you to start taking that. No, anyway. So yeah, I don't remember when I started taking it, but it was as an adult. It wasn't,
A young adult, a very young adult.
well, thank you. Thank you. So yeah, just keep in mind that, there's different reasons to take hydroxyurea. One of the facts that sold me on hydroxyurea is that it decreases mortality in sickle cell. I said
Right.
that alone, like if I'm gonna live longer, then yeah, I'm gonna take it because I have a daughter. And I
Yeah.
have a husband too, I guess I should. And family and friends and so on and so forth. But that alone, I was like, okay, if it's gonna decrease mortality, then yeah, I'll try it. I'll try it.
So
So yeah.
it's been around for a long time. And there's a registry of people who are taking hydroxyurea. So if you look into, if you're big on looking into the literature, there's a lot of literature about hydroxyurea. And what one study showed about mortality was that even if you weren't taking it, when they looked at when they did the data analysis, if you'd ever taken it, ever, even if you stopped taking it, you lived longer than people who had never taken it. So the effect of hydroxyurea, if it works for you, is really pretty. It's you can't. I personally can't really understate how well hydroxyurea works for some people. I just want to say something that I saw something go by here because iron overload, because I was a transfusion doctor, it's really a big deal for me because I've seen more than one person die from iron overload, and it is really a really um, very difficult. I mean, it's dying from iron overload is really terrible. It's terrible. So somebody said, is there some kind of food I can take to decrease my ferritin? And the question is no. But if you, what you should be looking at in your diet is if you're on chronic transfusions and you have a high ferritin, meaning you've got a lots of iron deposition, is you should make sure you don't eat food that contains iron because you can't, if you can, and supplements that contain iron because your body can take in iron through your GI tract, but there's no way to get rid of it. It just stays in your body forever. And the weird thing about it is if you get transfusions, your body can regulate through your food how much iron gets absorbed. But it can't get rid of it. Once it gets absorbed, it stays there. But the transfusions bypass that. There's no it. You just get all that iron, and it as the cells hemolyze, get old, that iron gets stored in your body, and that's what causes iron overload and an increased, and it comes out as an increased ferritin or a change in your liver biopsy or an MRI study. There are oral drugs now to reduce your iron, and you should really be on those religiously if you're on chronic transfusions. Once your iron gets up to a high level, it's really hard to get it down. The best thing to do if you're a parent and your kid is on chronic transfusions for stroke risk or something, just don't ever let it get up. Because once it gets really high, it is really hard to get it down. But if you start taking chelators, when you start your transfusions, once the doctor tells you your iron level is high enough, now we should start doing chelators. Do those, don't stop while you're on transfusions, and communicate with your doctor. Find out what your iron level is, what your ferritin is, what does that mean, etc. And somebody says Desferal is what I took, and I can remember Desferal. That was not a
That's
fun
old
medication.
school. Yeah.
Had to take that at night usually, but some people who are very iron overloaded took it all the time, and it was a needle just under your skin. It hurt, caused welts. It was not pleasant. You could take it intravenously if you were really heavily iron overloaded. But today we have oral iron chelators, and people waited for that forever. They kept saying, well, I don't take my Desferal, but boy, if there was an oral iron chelator, I'd take that. Well, that didn't quite happen. But it could, and you can, don't feel like, oh, my iron's so high, I give up. You don't do that because you can keep it where it is or get it down if you take oral iron chelators. And your doctor, if you're really, let me give you oral iron chelators and IV Desferal or something. I mean, there is a way to get it down, but the best thing is don't ever let it give up. And 1,900 is not normal, but if you could keep it at that and you're on chronic transfusions or get it down to 1,000, that would certainly be like a minor miracle. Good job.
All right. I see this question. Thank you guys for being patient with your questions being answered. I'm currently at the hospital at UCLA, and a doctor told me that opioids can cause more pain episodes. Is that true? And then I'm going to answer next, just so you guys know. What are the high levels of hemoglobin for sickle cell patients? You shared that hydroxyurea isn't beneficial for sickle cell. So we'll talk about opioids causing pain, if it causes more pain crisis than that high level, just to let you guys know.
Opioid is a really, opioids are really very, it seems so simple. You just take this pill, maybe it makes you a little sleepy, but your pain goes down. What what could be better than that, right? But opioids have a lot of side effects. They're not as specific as you'd like them to be. So yes, if you take opioids, you can have what's called hyperalgesia. The opioid itself kind of does the opposite of what it's supposed to do. So if you're taking, there's two things that can happen. You're taking your opioids in the hospital and the dose is going up and your pain is going down, but not that great. Well, that could be tolerance. Everybody who takes opioids, they have tolerance. You need more opioid to get the same effect over a period of time. And that period of time is different for everybody. But then there's something else that happens. You're taking opioids, they're increasing the dose, and your pain is getting worse. That doesn't make any sense, right? But that's hyperalgesia. So opioids can cause pain if they're given for some people, and the treatment for that is to start slowly weaning off your opioids. And as you do that, surprisingly, your pain starts going down a little bit and you can wean yourself completely off. You can't, most people can wean themselves completely off after they have a pain episode, but you can't go cold turkey. If you've been in the hospital for a week or whatever, 10 days, and you've been on opioids the whole time and think, okay, I feel better, I'm just going to go home and I'm not even going to fill my opioid prescription because I'm fine, I don't need it. Well, 3 or 4 days later, you're going to be kind of sick because you're having withdrawal from the opioids you were on for the 10 days. So when you leave the hospital, make sure that you have that somebody gives you opioids to wean off. So when you leave the hospital, you don't come back in 3 days sick as a dog. You can just go wean off it. Maybe it takes a week, 2 weeks, depends on how long you've been on it, etc. Its withdrawal is tough if you don't have some kind of, that's what someone just says, if you don't have some kind of plan to get yourself off of it. The other thing is pain is, sickle cell pain is not like any other pain for any other. You can't talk to another person who has a different problem and think their pain is like your pain because you have sickle cell. It's not. Sickle cell is different than everybody else's pain. But it shouldn't be, it is in some people, but rarely it is people have pain all the time. And those are the people who should be on hydroxyurea, some other medication, maybe chronic transfusions. But even if you get a bone marrow transplant, you're cured from your sickle cell disease, cured kind of. You have this transformative therapy. You can still have pain for 6 months after that, even though you look at your blood, it looks normal because it's your brother's blood or something like that. So that pain is, and it has a lot of other side effects, constipation, it affects your hormone levels. It's got a lot of side effects, and you should talk to your doctor about all the problems you could have if you're on chronic opioids. Decreases your libido. Opioids are not benign. They have side effects.
Okay.
Opioid-induced hyperalgesia can be diagnosed, but there's no test. It's just like pain. When you go to the ED and the doctor says, well, I looked at all your tests and I don't think you have pain. Well, there is no test for pain. What is that guy talking or that lady talking about? The hyperalgesia, there's no way, it's your personal experience that your pain is going up as you're getting the opioids and maybe even increasing them, and it's not working, your pain just going up, 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 up. And and you also always should be on a stool softener or something the minute you start taking opioids, because you will get constipated if you're on opioids long enough. And that's not fun. Pain is real. It's not well, your response to it may be subjective, but it's real. It's objective. You have tissue damage and something, and that really hurts. Inflammation, all kinds of what they call cytokines going all through your body, and it works on your nervous system. It works on your, it's huge. It's really a very complex, complicated problem.
What are high levels of hemoglobin for sickle cell patients? You shared that hydroxyurea isn't beneficial for SC, particularly type SC. So what
So
is what
yeah,
are normal
people,
hemoglobin ranges? Where's sickle cell?
yeah.
And yeah.
So sickle cell disease is sort of multifactorial. People who have the same exact, they have hemoglobin SS or S beta zero thalassemia, though it's unpredictable what your hemoglobin is going to be. Some people, when people look at it and they say, oh, the average hemoglobin for someone with SS is 8 or 9. Well, that can't be true. But I definitely had people I took care of whose hemoglobin was 6 and 7 all the time. So it's a wide range. So that's SS, beta zero thalassemia. But SC disease or S beta plus thalassemia, then your hemoglobin starts getting higher. And people with SC can have a hemoglobin 12, probably not too much higher than that, but around 12, 13, something like that. It would, I'm sure it could, but I never had a patient who had SC and had a hemoglobin of 14 or 15, which is totally like what my hemoglobin is. The problem with hemoglobin SC is that when you get sick, your hemoglobin is really high already. So what can you do about it? What if you had acute chest syndrome and you're really sick and your hemoglobin is already 12? Then you can't get a blood
Blood
transfusion. It's not going to
transfusion.
do anything, because if you
Yeah.
go up too high, your blood gets really thick and viscous and you can have a stroke. That's like the worst thing. So what you have to have if you have SC are exchange transfusions, and they can be automated exchange transfusions or a manual exchange transfusion, which is really a hassle. But if you're really sick and you've got acute chest syndrome, some uh, life-threatening event, then you need an exchange transfusion when you have SC.
So normal ranges, like what's your hemoglobin, Dr. Q?
My hemoglobin is between 14 and 15. It's around
So
14.
14 and 15, and
Yeah.
somebody with sickle cell
And
could be
if I wasn't a guy, my hemoglobin would be probably less than that, like maybe 13 to 14. Women have lower hemoglobins than men.
so I say this because it literally shows that we have about half of the hemoglobin or our blood than a typical person. So if you guys are feeling tired, believe that tiredness. It's not
Yeah.
your brain. You are not lazy. You are not anything other than you have less blood. And not only do you have less blood, your blood doesn't work the way it's supposed to work. So one, you have less blood, and two, the blood that you do have doesn't attach onto oxygen, or oxygen doesn't attach onto it as well as typical, I hate using the word normal, as well as typical blood. So you are tired for a reason. You are in pain for a reason. And I saw this one video on TikTok where, this phlebotomist looked at sickle cell underneath the microscope. You could see the sickles, like you could see that these blood cells are different than typical blood cells. So like don't and you know how we get in our head about like, is it really me? Is it really us? Like, am I really being lazy? Because I at least I do. Maybe you guys, if you guys don't, please teach me because that's where I need to be. But you know, you really be thinking, oh wow, I'm really just being lazy, or oh wow, I'm really just like, not trying it today. Um, so that is that's what I even like, you gotta remind people around you constantly. Because when you have sickle cell, like we make it look good. Like we make it look like we're a typical person. We make it look like our hemoglobin is 10 a lot of the times, like I'm a mom, I have a 10-year-old, I'm taking her to school, I'm dropping her off, I'm working, I'm doing this, I'm doing that, like I have a hemoglobin of 10, but I don't. And so people around you see you doing good or trying, see you trying to actually have a productive life, and they forget that you're using, or you're literally working off of half a gas a tank instead of a full gas of tank like everybody else. So you got to remind them, oh, like if I'm sitting down, oh, don't, nope, just give me this time. Let me rest because I have half a tank. You have a full tank. You always have a full tank. You go ahead and do it. If I rest, like trust me, I need it. I need it. And then that's just the fatigue part. We're not even talking about the pain. So just you might have to remind yourself often and do it as often as you need to, but remind yourself you are dealing with way less than a typical person. You're dealing with way, way, way less. Like it's like you're trying to make everybody has $100 in their pocket and you're trying to make 10 cents stretch and be equivalent to that $100 that everybody else has in their pocket. So just think of it that way. You're doing good with what you're given. And yeah, I just want to say that because it's one of my favorite facts that I love to tell people about sickle cell. Oh, what's your hemoglobin? Oh, you know what mine is? Oh, okay, yeah. So yeah, it's
So
my
so
soapbox.
feeling tired and being fatigued, like I think there's a difference. I can't really, only Cassandra on this knows for sure, but people talk about being tired and then they talk about fatigue, where you just can't, you're like walking across the room. You just gotta like force yourself to do it because you're so fatigued. And this all kind of ties into, in my mind anyway, is mental health in people with sickle cell disease. If you're tired all the time and you can't do what other people can do, that has to affect you. So people who, especially as you get older, I think you need to have someone to talk to. You need to have someone who understands what you're going through, and that's why sickle cell groups, where you can get together with other people who have sickle cell disease and kind of have community. That's really important, because what I used to tell, what one of my pet peeves was PE instructors at high school and middle school used to make the kids with sickle cell run laps,
Mm-hmm.
and
The
they got
mile.
yeah, they got
Mm-hmm.
dinged if they couldn't keep up.
That
And there
happened to
they are,
me.
they've got a hemoglobin of 7. Everybody else has a hemoglobin of 14. So there's no way you can't, you might be able to run 50 yards really
Which
fast,
is
but you
what I
can't
did.
run a mile.
The short distance, I gave it everything I could. And then after that, you just see me on the sidewalk sitting down.
Right. So it's like you can't, and if you're a parent and you have a kid who's like 10, 12, or an adolescent, and they need to have an IEP or a
Yeah.
50, what is it, 504,
504 plan. Yeah.
yeah, that says you can have water, you can go to the bathroom, and you don't have to run during PE. If you
Yeah.
can do other things, you can walk a mile
Yeah.
with a lot of water, but you can't run a mile. There's no way. And we just on the news, there was a whole team of, I forget if what were they, lacrosse or something, And the whole team ended up, these are all white guys without sickle cell. They all ended up in the hospital with rhabdomyolysis, which is what people with sickle cell trait get. And why? Because some person who they thought was their kind of workout guru had them running around in this really heavy duty workout, but obviously they weren't drinking enough water. And so with sickle cell disease, where you need to have that water, if it's hot out, if you're taking a hike, whatever, just always have water. Always. You can't get very far without water.
Yeah.
I'm trying to look and see.
You're probably closer to some of the more current questions. I'm still typing away at your guys' questions, so Dr. Q, feel free to take the next one.
No, I can't see them. They're kind of getting fuzzy as they go up.
Okay. Let's see here. So we talked about hemoglobin levels. I'm not sure I understood this question, but I'll ask it and feel free to. Oh, actually, okay, here's a question. If someone isn't a candidate for hydroxyurea, what options do they have for an abnormal TCD? And TCD is the test that scans for strokes and stroke probability. Is there a protocol established for abnormal TCDs to reduce the risk of stroke? So
Absolutely.
such a
There is,
sophisticated question. I love it.
yeah, but if you have a kid, anyway, so this is the deal with TCDs. TCDs were developed by a really great doctor, and they have the potential, if everything's done right, to prevent strokes in everybody with sickle cell disease, at least in developed countries where they can do a TCD. So there's a criteria that's used for abnormal values. Conditional means they're not quite normal, but they're not quite abnormal either. And then there's normal. And so if you have an abnormal TCD, sometimes the velocity on this, which is what's being measured, how fast your blood goes through the blood vessels in your brain, sometimes that velocity is so high, they take one look at that and they put you on transfusions. But the protocol says you have an abnormal TCD, and within a couple of weeks, you have another one. You still have an abnormal TCD, then you go on transfusions, chronic blood transfusions. And when I was involved in this, that meant you were going to be on chronic blood transfusions for the rest of your life. And some people still are. So what we tried to do is get as many of those kids on exchange transfusions so they wouldn't have to worry about iron. Because at the beginning, we thought these kids are going to be on transfusions until forever. And so we didn't want to have a lot of children and young adults with iron overload, because that's really bad. And then a guy named Russell Ware, I can't remember exactly the year, but he is big on the hydroxyurea, bigger than me even, probably. And he looked at people with abnormal TCDs on chronic transfusions, but we always knew that not every single person who had an abnormal TCD was going to be at stroke. But there's like 10% or something people felt statistically whatever. So he looked at and made criteria that if you had an MRI that didn't show any abnormalities and you didn't have any major neurovascular problems, that you could be weaned off of your transfusion and onto hydroxyurea. And once you were weaned off, a hydroxyurea was equivalent to transfusions. But weaning means you slowly stop the transfusions, you slowly increase the hydroxyurea. And as far as I know, that was not part of the protocol. It just said do that. But that means that people who have abnormal TCDs with normal that meet this criteria can go on to hydroxyurea. But in my mind, that means you're going to be on hydroxyurea for the rest of your life, which is a lot better than being on transfusions. But there are certainly people, children, young adults, adults who are still on transfusions because they had an abnormal TCD. And it's not, in my mind anyway, maybe other people have a better handle on this, but in my mind, if you don't have a normal MRI, I think you're kind of have to be on transfusion. I don't know if as an adult you could stop the transfusions even as an adult. What does happen is you become an adult, the hematologist says, oh, you're on transfusions, you're kind of iron overload, I'm going to stop the transfusions. Well, this is not a good idea because then you'll have a stroke or some other problem. So.
We have a couple more time for a couple more questions. I want to answer one quickly. Wait, somebody said, wait, is hydroxyurea okay for SS patients? Yes, it's okay for SS patients. And the question earlier was regarding SC patients, and that I want to segue into a question here that says, can you please explain the difference between SC and SS, please? So I guess I can start this off by saying there are different types of sickle cell disease. So if you think of the term sickle cell disease, there are different types that fall underneath that term. So sickle cell disease means you can have different genes that you inherit that causes sickle cell disease. And so the most common type, and we call that genotype, is SS. And then you have, secondly, SC, type SC, sickle cell disease. And then you have S beta thalassemia, sickle cell disease. And then you have a whole bunch of other ones that are a little bit more rare. And so that's essentially, and so all of those types fit under the term sickle cell disease. You'll hear the term sickle cell anemia. Typically, that's only for specific types of sickle cell disease. So if you have for example, I have sickle cell anemia because I have type SS. As Dr. Q said earlier, if you have SC, you probably have a higher hemoglobin, which means you should technically, and I'll say technically, right? But each person is their own. You should experience less fatigue so you don't have that anemia. And Dr. Q, please correct me if I'm wrong. So you have sickle cell disease, but you don't have sickle cell anemia. Whereas people with SS and people with S beta thalassemia 0 have sickle cell anemia. So I'll stop there. Please correct anything that I've said wrong. And yeah.
Cassandra's never wrong.
I try not to be.
She is the sickle cell expert here, not me.
I've only learned from you.
Now I can't remember. What was the question?
So the difference between SS and SC.
Okay. So SS, well, obviously, if you have SS, you've inherited hemoglobin S from both of your parents. So you can only make sickle hemoglobin. And those are people who would say you have sickle cell anemia if you have SS or S beta 0 thal. So SC, you inherited S from one parent and hemoglobin C from another parent. Hemoglobin C is not does hemoglobin C does not sickle as the oxygen goes down. So you don't have as much sickling as a person who has SS or some other types of sickle cell disease. In in spite of that, and so your hemoglobin's higher, right? But in spite of that, you can still have problems. It's
Yeah.
even people with sickle cell trait have problems. So
Right.
we're not talking about sickle cell trait. We're talking about sickle cell disease, SC. So you can still have problems. The main one for hemoglobin SC is you have a really high hemoglobin, relatively speaking, and so your blood is more viscous than people with SS. Their blood is really thin because they don't have very much hemoglobin. Your blood is a little bit thicker because you have a high level of hemoglobin. If someone with SS got transfused to a hemoglobin of 12 or 13 from a hemoglobin of 6, they would probably have a stroke because that is just too viscous for the remaining sickle cells that are still in circulation. So hemoglobin SC does have a lot of problems, or does have problems. The main one for children and young adults is they can get retinopathy. Because the vessels in the back of your eye and the retina are really small, there's a lot of blood that goes through there. You can develop blindness from retinopathy. So that, to me, right off as a child, that's something we got to check every year at when at some point to make sure that you can prevent blindness in people with SC disease. The other thing is you can have things happen to you just like people with SS. So for instance, you can have splenic sequestration. In SS, that happens to kids like 18 months, around that age. Their spleen, the blood sickles in their spleen, it gets really big, and it gets so big, and the kid is not very big. It can sequester or trap all of the most of the blood in the person's body, and they can die from that. A baby can, and there's no real symptoms. So you have to teach a parent, if your kid doesn't act normal, feel and make sure they don't have a big spleen. If they do, bring them in right away. Well, that doesn't happen in SC disease that I very often. Everything's possible in medicine, but it does happen when you get to be older. You're an older teenager, you've got kind of pain on the left side, and you feel there, and there's kind of a lump. Well, you're having splenic sequestration, but it happens much later in people with SC disease. The other thing that's really, I hate to be so negative, but I guess you have to be honest. So the other thing that can happen with people with SC disease, and this is usually adults, not kids, but they can have multi-organ failure. Your hemoglobin is so high that if you really, really get sick, you can have acute chest syndrome, stroke, renal failure, and not survive without exchange transfusions and a lot of like intensive care, ICU type care. If that happens to you, it's called multi-organ failure. And that's why even if you have SC and you don't really get sick very much and you have chest pain or you got trouble breathing or something just not really right, you need to go see the doctor because you don't want to wait until you're taking an ambulance to the hospital. Have call your doctor, have yourself checked out. um, SC can be just as bad, and in some cases with multi-organ failure worse
Yeah.
than hemoglobin SS. I don't want to scare people, but it's something you need to know, that people with SC, usually adults, can have multi-organ failure, but teenagers and younger kids, it's possible, but not as common.
Yeah, I saw an article that came out, I think just recently, and they called SC the like the forgotten genotype, or the lesser known, or lesser, like, they don't pay attention to SC as much as SS. And that's because in textbooks it says SS is, more severe than SC, because of the anemia and everything that Dr. Q explained. And so I think research is pivoting in a way to like be a little bit more inclusive towards SC, because if sickle cell is an individual thing at the end of the day. And, I know people with SC that are in the hospital more than me, and I have SS. So it really does require kind of just more care and more thought and more research surrounding SC particularly, because I know a lot of the research goes towards SS, or SS is prioritized. Um, so yeah.
So if you have SC, I think what you need to do is do what people with SS do. Make sure you're hydrated all the time, have a good diet, exercise up to you know your own body. Don't try to decide you're going to be a mile track star without maybe like working up to it. People with that, a lot of times when you hear about people who are famous and they're a entertainer, or maybe they do some kind of sports and they say I have sickle cell disease. Many of those people have SC disease. So people who have SC disease really can excel, but you have to take care of yourself. You have to remain hydrated. You have to you have to be monitored, especially for the eyes, to make sure your heart, your lungs, your eyes, your kidneys are all working okay. And the best thing is to have a good diet, drink lots of fluids. Um, don't don't get yourself into a situation where you have adult onset diabetes, where you put on a lot of weight and then all of a sudden you have diabetes. That would not be too good for a person with SC disease, because then you'd have two diseases. So you've got to really monitor your health and try to stay as healthy as you possibly can. So.
Also, somebody asked if there's a gene therapy to cure people with SC. I know a couple people with SC who have been cured. I'm not sure if it was through gene therapy or if it was through bone marrow transplant, but that's definitely an option if you're looking to pursue curative options for particularly SC. Um, there are people who have undergone cure for SC.
Yeah, I think somebody with SC did get gene therapy. So, just like SS, there's a spectrum of severity of all kinds of
Yeah.
sickle cell disease, and some people with SC disease that have genetic mutations that we just don't know what they are at this point, which is something for research to figure out in the future. That combination with sickle cell disease, SS or SC, makes it worse. And so there are people with SC. I had people, at least one person on hydroxyurea, and they did better with their SC, even though I couldn't really see the difference. But hydroxyurea has a lot of effects besides increasing your fetal hemoglobin.
And gene therapy is approved for adults.
Yeah,
I don't think is it approved for
12,
children?
12, 12 and up.
Oh, okay. Yeah, there's two approved gene therapies in the US as of December last year. So yeah, there is a gene therapy that we talk about, and we really want to define what cure means, or just not use the term at all, because it gives people an idea of what life could be, an unrealistic idea of life. And so I think the term, you'll see us use curative slash transformative. I think the community is looking to adopt the term transformative so that they think it's more representative of the process than to say cure. What about S beta thal zero? S beta thal zero would be sickle cell anemia. So that would be one of the types of sickle cell that would be considered sickle cell anemia. The last question I wanted to ask is this person said, I'm on apheresis treatment and I'm still having pain, and my doctor keeps saying my pain is chronic, but isn't chronic pain, but isn't chronic pain common with sickle cell too?
Chronic pain is common with sickle cell disease. Um, and even though you're on apheresis, you need to, you've probably done this already, but you need to know what is my percent hemoglobin S before I come in for my transfusion and after I get done with my transfusion. And what can I, if you have chronic pain and you're on apheresis and you're getting regular transfusions every month or whatever, and you're still having pain, you you probably need to be seen by a pain expert, whether that's a sickle cell doctor who has an interest in pain or somebody who is like a pain specialist. There's a lot of reasons to have pain. Like I said, um, your opioids affect your entire body. Pain affects your entire body. It changes the way your brain works, the way your spinal cord works. So it's very chronic pain is not really common in people who have sickle, who are on exchange transfusions, but everything's possible. And I think if your hemoglobin S is low enough, through that whatever 3-week, 4-week cycle, and you've been on it long enough, then your expectation should be that you don't have pain. And if you do, then you need to see a specialist to figure out how can we get you in a place where you don't have pain. If you're much older and you've had pain, chronic pain, before you started your apheresis, then that's a bigger problem. It might be harder to fix.
Folic acid does not make iron overload worse,
No,
correct?
that's correct. The only thing that makes iron overload worse is something with iron in it, like breakfast cereal. Some breakfast cereals contain iron.
Some supplements, some of those
Oh
supplements
yeah.
that you guys take, not you guys, that we take, because I take supplements. I don't know what, don't mind me.
I
Some of
can
the
say
supplements that we take
that.
contain iron. So yeah, there's a lot of information that goes around in the community that says, oh, the reason we have anemia with sickle cell is because we have low iron. That's incorrect. We
Right.
Anemia can be caused in different ways. We actually have a genetic mutation that causes anemia. So you could be like me though, right? Where I have iron deficiency. So I have to take iron. But the reason I'm anemic, so the reason I'm anemic is a twofold for me. It's sickle cell and iron. But the reason most people are anemic because of sickle is because of sickle cell. It's not because of iron deficiency. So you have to be careful, especially if you're getting transfused. You have to be careful that whatever you're eating, whatever you're taking, spinach has iron in it, whatever you're taking, you understand how much iron you're putting into your body. And, that all adds up and could cause iron overload. So don't just be taking iron supplements because that's what you think is going to be fixing your sickle cell. We have anemia for different reasons. We don't have anemia for iron deficiency. We have anemia because we have a genetic problem. So remember that, and then maybe as you're getting labs and your doctor says, "Oh, your iron level is really, really low," then you can take iron supplements, right? To offset that. But don't just be taking it because that can be dangerous, okay?
Yeah, so there are tests that can show that you have iron deficiency. And if you have, a significant anemia or you develop a significant anemia over time, then those tests could help figure out why do you need, like, maybe you need vitamin B12, maybe you need some other kind of
Yeah.
vitamin, maybe you do need iron. But there are tests to show whether or not you're lacking those um, vitamins.
You guys, I said I was wrapping up and y'all are still sending questions. Okay, okay. Maybe I'll answer one more. It says the doctor, my doctor said I have the worst severe one. I'm assuming they said you had the worst severe type of sickle cell. Which one is that called? Textbook wise, it would be type SS, and that's the type I have. That's the type most people with sickle cell have is type SS. So, but you can get it confirmed through lab test, through electrophoresis to see what your genotype is or what type of sickle cell you have. All right, Dr. Q, I'm gonna let you have your special moment.
My special moment. Yeah, well, so what Sickle Cell 101 does and what I try to do is just give you information. Information, knowledge is power. The more you know about your sickle cell disease, the more you can help yourself and you can help your doctor take care of yourself. So our job is not to promote any kind of medication, treatment, transfusions or anything. We just try to give you what we feel is information that you need to help with your take care of yourself with your sickle cell disease. There is ask at Sickle Cell 101, and I answer those asks and try to give you a good answer for whatever question you have. Usually I can get back to you in 24 hours, but if it's a real hard one, I look things up, in the literature to make sure that I'm giving you the right information. But I'm not trying in this program, and when I answer your questions, I'm not trying to advocate for any particular therapy or treatment. And you should always ask your primary care physician what's best for you. I don't know anything about, well, I actually do know some of the people that come on here, but but I don't know anything about you, and I don't know anything about your complications or your problem with sickle cell. Only your doctor knows that, and that person can help you get the right therapy for your sickle cell disease, not me.
Okay. I'm still frantically writing down your questions. I'm so sad we can't get to all of them, but like Dr. Q said, if you have a question that you really, really, really want answered, please send it to ask@sc101.org. Like Dr. Q will probably like send you a research paper back. That's how like thorough it is, guys. So if there was any question, I'm so sorry we couldn't get to it. I really want to. There was a question that I really want to get to, but it
That's
was
fine.
about organ damage in SS, and I'm so sorry I couldn't find the question. So please send it in to us. Yes, jaundice causes yellow eyes, and stay hydrated if that's the case. Make sure you're drinking water. Um, Thank you guys so much. Let me just thank you. Thank you for being here today. Thank you so much.
Yeah,
And we will be back in 2 weeks. So if you want to
right.
join us on live in 2 weeks, we will be back. And you can ask your question there. But if, like I said, if it's urgent, please send it to ask@sc101.org.
Even if it's not urgent. And we start Pacific Standard Time, we're starting around 10 o'clock.
Yeah.
So if you're
And we
somewhere
usually have
else,
a story up that says, hey, send in your questions as well. So
right. And that usually we start this with the questions people send in. So if you send in
yeah.
a question, around the time that we're doing this little program, then that question will be answered first.
Yeah. Okay, you guys really got me. Like I'm really feeling bad logging off today, but please send us your questions or we will be back in 2 weeks. All right.
Right.
Have a
Okay.
wonderful
Thanks so
weekend.
much,
Be safe.
everybody.
Make sure you
Stay safe
rest and take good
and
care of
stay
you.
well.
Yes. All right. Bye, guys.
Bye bye.